Thank you, Chairperson. Thank you, Dr. Vijay, for the opportunity. So another 15 minutes time, I'll be taking you through the NAFLD and how the name has been modified and how do we diagnose it and how does it progress and how do we intervene in. And the prevalence of NAFLD with various studies. By looking at the studies itself, we know there's a lot of variability and almost they say 25% worldwide, something like describing an elephant in the room. Indian study shows 38.6% and in the patients with metabolic disorders, it's almost 58.2%. And in a pediatric age group also, it's alarming, it's saying 35.4%. So the NAFLD commonly associated with metabolic conditions. If you look at the metabolic condition, obesity, almost 90% of the people with obesity have this NAFLD. Type 2 diabetes, 70%. People with height, we had a talk about the triglycerides, almost 83% with the people with high triglyceride, and hypertension, 68%, and the other metabolic syndrome also. And that is why there was a need to revise the nomenclature of the NAFLD because of strong association with metabolic disorders. So it was termed as, from NAFLD, it has been changed to, from the non-alcoholic fatty liver disease, now we have changed to MASLD, the metabolic dysfunction associated steatotic liver disease. What does steatotic liver disease means? When there is more than 5% of the fat in the liver, we call it steatotic liver disease. When it has got an association of at least one cardiometabolic risk factors like elevated triglyceride, low HDL, type 2 diabetes or pre-diabetes, obesity and high blood pressure, it can be called as MASLD. And the renaming as MASLD nomenclature was released in the June 2021 in the European Association on the Liver Conference, accepted and signed by various stakeholders involved in the liver disease and management throughout the world. And so according to the clinical experience, is prevalence of the MASL in India underrated? And who comes first? The egg and chicken story, which has come. Mutti vandada, koli vandada, kunju vandada, koli kunju vandada, whether type 2 diabetes has come first or the MASL has come first. But if you look at this, the insulin resistance is the root cause for the development and add for the MASLD. So what happens to the insulin resistance? Can lead to hyperinsulinemia as well as hyperglycemia. There can be adipocyte dysfunction, which leads to the reduction in adiponectin, free fatty acid and triglyceride, and hyperinsulinemia and hyperglycemia due to various factors which act on a healthy liver on the background of an environmental factors like dietary factors and sedentary lifestyle with a genetic predisposition. The healthy liver is converted to a fatty liver. From the fatty liver, again, inflammation, apoptosis, and oxidative stress. We call this as a lipotoxicity. The fatty liver has been converted into NASH, non-alcoholic steatohepatitis, and this can be, the NASH can be a part and parcel of the type 2 metabolic diabetes and metabolic syndrome, and also the end-stage liver disease. And this data shows that type 2 diabetes can lead to progression of fibrosis at higher rate in NAFLD, which is a prospective study. You look into the graphic, you know that as the years of diabetes goes on, the diabetes versus non-diabetes, the progression in fibrosis was more severe in people with type 2 diabetes compared to the non-diabetic population. Again, the mortality also, the first part of the slide shows in non-diabetic people, they have given a data that almost 25% of the US population have NAFLD in the non-diabetic population. The conversion of NAFLD to NASH was 10 to 20%. From NASH to cirrhosis was 10 to 15%. The cirrhosis to hepatocellular carcinoma was 3%. And the hepatocellular carcinoma requiring the liver transplant almost 14%. The cirrhosis and liver transplant, the hepatocellular carcinoma, all increase the mortality. But when they look at the down part of the slide, you can see almost the risk is double. So the type 2 diabetes, the progression of NAFLD to cirrhosis as well as the mortality is higher. And this data shows that the NAFLD is developed before then type 2 diabetes. This is a meta-analysis of almost 33 studies which involve almost 5 lakh individuals. 30.8 of them had NAFLD, almost the 27,000 people had diabetes over a median period of 5 years follow-up. They looked into all NAFLD patients, severe NAFLD and liver fibrosis. There are almost, 2695, almost around close to 40 studies. You can look into the risk. Relative risk was definitely higher. So the NAFLD is associated with 2.2-fold increased risk of incident diabetes, which is directly proportional to the severity of NAFLD. So this is again looking at whether the NAFLD leads to new incident diabetes. This is definitely, this was the relationship between the NAFLD and type 2 diabetes is dynamic and reversible. I said the chicken egg story. You can see the different groups, group 1, 2, 3, 4, 5, 6, 7. This study was, the objective of the study was to assess the risk of incident diabetes with variable liver statuses over time, determined that their sustained NAFLD group had a significant increased risk compared with the never NAFLD and intermittent NAFLD group, almost 3,000 patients followed up for 14 years. So the different groups, group 1 did not know NAFLD, group 2 persistent NAFLD, group 3 NAFLD developed at midpoint of follow-up, and the group 4 NAFLD resolved at midpoint of follow-up, and then other group NAFLD resolved in last year of follow-up, and the 6th one NAFLD developed in the last year of follow-up, and the 7th group of recurrent NAFLD. Look into all the things, definitely look into the NAFLD certainly led to a new incident diabetes, all where the higher hazard ratio was higher, and so the NAFLD is more useful in predicting incident diabetes onset than BMI, even when considering change over time. So we are talking about the BMI time and again. Now look at NAFLD and predict the chance of developing type 2 diabetes. And again, this is a study, almost it's a landmark analysis. The duration of type 2 diabetes and liver-related events in NAFLD, which was published in Hepatology. Almost they tried to look at the landmark analysis at 4 different ages of interest, like biological 40, 50, 60, 70, almost which include on 30,000 patients. You can see easily the longer the duration of type 2 diabetes is significantly associated with the higher risk of liver-related events and all-cause mortality in patients with NAFLD. So a patient developing NAFLD with a type 2 diabetes, longer the duration, the liver-related event is higher, as well as the risk of all-cause mortality is also higher. Again, they're looking at the MASLD associated with more CV events compared to the NAFLD. Again, we're talking about the high triglyceride is now considered as the cardiovascular risk factor for fatty liver patients. So whenever a patient with steatotic liver disease comes, there is the hepatic steatosis identified by the imaging or biopsy. Second, does the patient meet any of the cardiometabolic criteria? If yes, what do? Are there any other causes of steatosis? If yes, probably this can be given a different category and looking at the combination etiology. If there are no cause can be identified, it's called as metabolic dysfunction. I think slides are gone. So it's been associated with the metabolic dysfunction associated steatotic liver disease. On the other hand, if the patient does not meet the cardiometabolic criteria, are there any other causes of steatosis? If there's no causes of steatosis, we can call it cryptogenic SLD. On the other hand, specific etiology like alcoholic liver disease and monogenic disease. This is how the fatty liver has been classified. And there has been interplay between the insulin route. I said insulin resistance as the root cause. Sometimes we call as the metabolic syndrome. The insulin resistant at the liver is the key. So here you can see the type 2 diabetes, high triglyceride, MASLD, insulin resistance, all are one leading on to other, going like a vicious cycle. We need to break the cycle. And does the type 2 diabetes cause NAFLD or NAFLD cause type 2 diabetes? Which should be treated first? How do we diagnose first? This is what I just want all of you to just have a look at this slide. So how do we diagnose? So there are many ways. One, a patient with obesity, diabetes and metabolic syndrome. On the other hand, incidental detection of the elevated liver enzyme. Fatty liver screening through an abdominal ultrasound. Sometimes incidental detection of fatty liver through ultrasound, what do you do? Non-invasive testing for fibrosis by the FIB4 or NFS. So when it's a low risk, that is from the FIB score is less, you repeat in 2 to 3 years. If it's indeterminate risk, the vibration control transient elastography or blood test measuring fibrosis markers. If again this is a low risk, repeat it after 2 to 3 years. Whenever there is high risk, refer to a gastroenterologist or a hepatologist. This is very, very important, all of you should know. And how do the recommendations from various guidelines, almost all the association and stakeholders in liver diseases say that when do you screen for the NAFLD, obesity, type 2 diabetes, pre-diabetes and elevated liver enzymes, hypertriglyceridemia and low HDL and hypertension. And recommended initial screening methods are simple: AST, ALT and liver enzymes and abdominal ultrasonography. What is the FIB4 index, which can exclude presence of advanced fibrosis? Easy and cost-effective assessment method. Only needs 4 parameters: age, AST, ALT and platelet count. Can rule out the presence of fibrosis, which is higher sensitivity and specificity, recommended by all major guidelines, ADA, AAC and other guidelines. And when we look at that, whenever the FIB score is less than 1.3, advanced fibrosis is excluded. On the other hand, if the FIB4 score is more than 1.3, there's a second line test we need to do. We should do the elastography testing or MR elastography. We need to do confirming. What is VCTE? Vibration Controlled Transient Elastography. This is otherwise people call it a fibroscan. It's a dedicated system used to evaluate advanced fibrosis and is based on the vibration controlled transient elastography technology. There are 2 parameters are measured. One is liver stiffness measurement, it's in kilopascals. Other one, that control attenuation parameter. That the first is the liver stiffness measurement is a non-invasive quantification of the liver fibrosis, and the control attenuation parameter CAP is called as non-invasive quantification of the liver steatosis. Both parameters will be given. So in routine practice, which type of patient should be referred for MASLD screening, and what should be the stepwise approach in MASLD diagnosis? And very, very important, dear friends, the key approach in the management of the NAFLD or the MASLD is that lifestyle modification, diet control and weight reduction, and which is going to be one of very, very toughest. All of you will be agreeing when you look at it, whether you treat diabetes or any disease. I used to tell in many meetings, the adherence, the compliance with the medication is almost 80 to 90% by the patients. But adherence to the lifestyle is less than 50% in patients treated by specialists, patients getting regular diabetes education itself. So think about the people who are not at all being educated on diabetes and not treated by specialists. So the lifestyle modification is one of the toughest, but we need to emphasize diet control and weight reduction is the key. Again, managing the comorbid conditions like obesity, type 2 diabetes and metabolic syndrome, pharmacotherapy, and finally bariatric surgery. And what does the weight loss do? What does the evidence say? Say when you are going to get a 3% or more, 3+ % of weight reduction, there can be steatosis improvement. When the weight reduction is more than 5%, there's a ballooning inflammation improvement, almost 41 to 100%. And when you are going to reduce the weight by more than 7%, there's a NAS resolution approximately 64 to 90%. When you're going to reduce by more than 10%, fibrosis regression has been almost 45%. But what percentage of people follow, sustain the weight loss? When you look at it, almost initially you can see the 5%, 30%. More than 7%, 18%. When you look at the 10%, it's almost less than 10% only. So the weight loss, whatever percentage of weight loss, whatever kilograms of weight loss by any of your diabetic patients, with or without MASLD, it's always welcome. So please please educate and convince your patients to reduce weight by whatever means. Okay. And is it possible to manage MASLD based on lifestyle modification and weight loss for a longer period of time? As I said, the compliance with the weight loss is really difficult, and longer time, it's almost practically difficult, but we keep continuously enforcing them, continually educate them and tell them weight loss is very, very important. You look at the list of medications, many of the medications do not have, almost look at from the metformin, vitamin E, PPR, gamma agonist, PUFA, pentoxifilin, GLP-1 receptor, UDCA, obeticholic acid, and many drugs. Almost the evidence is very, very less. If we look at that here, you can see the PPR gamma, the European Association said consider use in selected diabetic patients, but the NICE guideline also says consider pioglitazone in adults regardless of diabetes. And again, the AASLD says that pioglitazone indicated in biopsy proven NASH. And so many other drugs, the list is there, but none of them are approved. Here this is saroglitazar, the dual PPAR agonist. You know that the PPAR alpha is found in the liver, kidney, heart and muscle and is implicated in uptake of oxidation of fatty acids and lipoprotein metabolism, and PPAR gamma is mainly expressed in adipose tissue with beneficial effects on glucose homeostasis by increasing insulin sensitivity and glucose disposal and prevent the loss of beta cell mass. So one, this alpha acting on the uptake and oxidation of fatty acid and lipoprotein metabolism. On the other hand, PPAR gamma improves the insulin sensitivity and glucose disposal. So the saroglitazar is a dual PPAR alpha and gamma agonist, and through activation of these transcription factors, PPAR and alpha gamma reduces triglyceride. Today the triglyceride is being much talked about. People were till last year, before, and people were telling whether the triglyceride has to be treated. Why should it be treated? So now the triglyceride is getting much importance. So this reduces triglyceride, reduces insulin resistance and control blood sugar levels predominantly through the PPAR gamma mechanisms. And there's a lot of studies. This is a biopsy-driven phase 3 trial which was done in India. In fact, I'm happy to share that I was also part of this liver biopsy-driven study for the saroglitazar, and it showed very good results. The decrease in NAFLD activity score of more than 2, the NASH score was observed in 52.3% of patients without worsening of fibrosis. It's a 52 weeks data. And I am using in many of my patients with the MASLD, the saroglitazar. And this again, the efficacy and safety of saroglitazar in real-world patients of non-alcoholic fatty liver disease with or without diabetes, including compensated cirrhosis. It's done in a tertiary care center with about less number of patients, but 52 weeks study. And this study was published in February 2023, and this was a EASL conference. It was published. Almost this is a 96 weeks follow-up study of this MASLD. Almost you can look at the LSM and CAP reduction, almost were 42% and 26%. And these patients, almost 53% were diabetic and 47% was non-diabetic. This is again, the International Association on this liver disease also says that 2020 recommends saroglitazar in NAFLD treatment for a minimum of 12 months. Okay, and it says that significantly reduces the fibrosis, liver enzymes, and with the phase 3 evidence. And almost the 4 major scientific bodies have approved the saroglitazar. These both Lipid Association of India, RSSDI, and Indian National Association of Study on Liver and Cardiological Society of Liver. Just coming to conclude my talk, just want to tell you this, the terminology has changed from NAFLD to MASLD. That is one I want to say. And the fatty liver, many times people think we just by, when you say fat, patient, doctor, cholesterol medicine saapta and the fat sariya biduma. People think. Sometimes yesterday one patient had a cardiac event and he did an angio. So the cardiologist said, calcium deposit aayirke. Sir, blood calcium check panni paathen, calcium low. Calcium tablet saapta heart la calcium deposit aguma. It's a lot of myths. So the fatty liver is no more a benign quantity. Please, whenever a patient comes, and always kind of look for it, and whatever, as I said, whatever percentage or kilogram of weight reduction you get in the patient is really will be beneficial to resolve the fatty liver as well as the fibrosis. So the metabolic dysfunction associated steatotic liver disease, which is redefined from NAFLD. The association of at least one cardiometabolic risk factors, obesity, type 2 diabetes, hypertension, high triglyceride, low HDL, and steatotic liver disease is considered as MASLD. Screening and diagnostic tests like ultrasound, FIB4 index, VCTE are strongly recommended. As I said, the lifestyle modification and weight reduction is the key or the first line management, but sustained weight reduction is a major challenge. Drugs like saroglitazar is only approved medication to treat NAFLD and metabolic disorders. Probably in the time to come, various drugs are on the pipeline in the research. So probably the next conference of Vijayakumar, we might be getting any other approved drugs for the managing the MAFLD. Thank you very much.